Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient and Family Learning Center at Mass General. Before I get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them. Today's going to be a little bit different. It's going to be a little bit more interactive. We'll pause in between the sessions, so feel free to enter your questions in the chat anytime. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I am going to introduce you all to today's guest speaker. Joining us today, we have Dr. Jean Lambert. Dr. Lambert is Medical Director of Addiction Medicine at Mass General, a multidisciplinary team comprised of clinicians, social workers, and peer support specialists with lived experience that provides comprehensive and holistic care for hospitalized patients with complex substance use disorders. His team provides innovative management of inpatient withdrawal syndromes, evidence-based pharmacotherapy for substance use disorders, behavioral counseling, and linkage to community-based services. His clinical interest includes the diagnosis and pharmacotherapeutic management of alcohol use disorders and alcohol use disorder cirrhosis. Dr. Lambert is double board certified in internal medicine and addiction medicine. He is a fellow of the American College of Physicians and the American Society of Addiction Medicine. In recognition of Alcohol Awareness Month, he joins us today to give a talk on alcohol use disorders. So please join me in welcoming Dr. Lambert.
Well, thank you. Let's share my screen here. And well, I'm happy to be here as part of Alcohol Awareness Month and talk about a disorder that is of my clinical and research interests. And I'm going to be talking about alcohol use disorders in the United States, where we are and where we're going, and hopefully give some sort of historical and current view of the complexities of how we, one, identify, diagnose, and eventually treat alcohol use disorders in this country. Unhealthy alcohol use, including alcohol use disorders, has significantly increased over the past decade. In 2022, alcohol use disorders were the most prevalent substance use disorders in the United States. Alcohol use disorders are associated with a number of medical conditions, including alcohol-associated liver disease, high healthcare utilization, which includes emergency department visits, hospitalizations, alcohol hepatitis-associated liver transplantations, morbidity and mortality. In this talk, I will review the current state of alcohol use disorders, its healthcare system impact and utilization. I will describe the increasing prevalence of the dual pathology of alcohol use disorders and associated liver disease, including the advanced liver disease entity of alcohol use disorder cirrhosis. I will discuss an addiction-focused and multidisciplinary approach to the effective treatment and management of alcohol use disorder cirrhosis. Objectives today include an overview of unhealthy alcohol use, defining what that is, including defining what DSM-5 alcohol use disorder looks like, review alcohol-related morbidity and mortality, highlight alcohol-associated liver disease, commonly known as ALD, and define the dual pathology of alcohol use disorder cirrhosis, and then discuss medications for alcohol use disorders, which we commonly call MOUD. Alcohol is associated with 58 acute and chronic diseases, which its use fully or partially contributes to onset and progression of these disease. There's emerging literature and research to recognize and treat complex alcohol use disorder. And that's alcohol use disorder associated with identifiable and predictable medical consequences. Alcohol use disorder cirrhosis is the most important representation of this dual pathology. And you will hear repeatedly from me and what I consider the most important thing in the care I provide to patients with alcohol use disorder or complex alcohol use disorder. Medications for alcohol use disorder is life preserving, more so in alcohol use disorder cirrhosis. I do want to level set and really make sure we all have a shared mental understanding of how we communicate and talk with patients who have a substance use disorder, not only including alcohol use disorder. Words matter. We need to treat every person with a substance use disorder, including alcohol use disorder, with empathetic, humanizing, and non-stigmatizing, patient-centered, equitable, high-quality, effective, timely, and efficient care, similar to all chronic diseases, for example, like diabetes, hypertension, ischemic heart disease. This care starts with using our words to create this narrative for each patient. And so we looked about stigmatizing language, and non-stigmatizing language has evolved. We don't say someone is an alcoholic or someone has alcoholic related liver disease. We now say that alcohol is associated with that disease or that clinical entity. Just some definitions so we all on the same page. I will be using these definitions as I go through my talk. When we talk about excessive alcohol, excessive drinking includes 4 domains. It includes binge drinking, where if you're a man, you're drinking 5 or more drinks on one occasion. If you're a woman, you're drinking 4 or more drinks on one occasion. It also includes heavy drinking. If you're drinking 8 or more drinks in a week for a woman, 15 or more drinks in a week for a man. And then it includes excessive alcohol use, which is detrimental and toxic to the in utero or the adolescent young adult CNS neurodevelopment. And that's any alcohol use by those under the age of 21 and any alcohol use by a pregnant woman. Harmful alcohol use is above threshold drinking associated with negative consequences. It's a spectrum that includes hazardous use, harmful use, and alcohol use disorder. It's associated with loss of control, compulsive use, and negative consequences, defining the disorder, alcohol use disorder. When we think about alcohol-associated cirrhosis, prolonged and heavy use is toxic to the liver, causing acute injury, which we see manifested as alcohol-associated hepatitis, and chronic injury and failure, which is commonly known as cirrhosis, which we will call alcohol-associated cirrhosis. In terms of an overview, alcohol use disorder is a complex and heterogeneous psychobehavioral disease that requires a comprehensive approach and management to prevent health consequences. When compared to other chronic medical diseases, alcohol use disorder has less rates of ineffective control and management, i.e. patients are more committed to adhering to their treatment plan compared to other chronic medical diseases. Individuals with alcohol use disorder and alcohol-associated liver disease require multidisciplinary, longitudinal, primary mental, behavioral, and psychosocial care. Medications have been associated with abstinence, reduction in use, and cravings and desires to drink. If it's associated with decreased hospitalizations, reduced incidence of alcohol-associated liver disease, and decreased mortality. Unfortunately, for a number of patients, there are provider and societal and patient factors that prevent medications from being widely used. In 2002, about 2% of individuals with an alcohol use disorder received FDA-approved medication for treatment. I'd like to talk about a model to optimize care of patients with alcohol use disorder. You'll see these principles or these different steps incorporated throughout my talk following the introduction of this model. The ADAP model is a personalized model to effectively manage persons with alcohol use disorder, including complex alcohol use disorder cirrhosis, across the continuum of a person's care. During this talk, I will address alcohol use disorder awareness, the identification and diagnosis of an alcohol use disorder, gender and racial ethnic disparities, and their urgent need to recognize and treat alcohol use disorder cirrhosis to prevent progression. And of course, more importantly, the use of life-preserving medications for treating alcohol use disorder. Let's talk about the epidemiology of alcohol use disorder. When you talk about alcohol use disorder from a global prevalence perspective, 33% of the global population, 2.4 billion individuals are current drinkers. Men, as you'll see in all our metrics related to alcohol use, whether unhealthy alcohol use or drinking, have a higher prevalence than women. 2.8 million deaths each year are attributed to alcohol use. Again, male to female predominance. It's the 7th leading risk factor for premature death and disability. 50% of the 1.3 million liver deaths are estimated to be alcohol attributable, again, with the male to female predominance, resulting in 22 million years of life lost due to alcohol-associated liver disease. There's only one level of alcohol that minimizes health risks. Consuming 0 standard drinks minimize the overall health risk of all health loss. So when you actually are a non-drinker, your relative risk of all-cause mortality is near 0. And as you continue to drink increasingly in terms of standard drinks per day, your risk of all-cause mortality increases exponentially. There's no level of alcohol use that is safe, and the only safe alcohol level, meaning avoiding the toxic effects of alcohol to many systems and organs in our body, is to actually drink no alcohol. Unhealthy alcohol use in the United States is a spectrum of alcohol-related behaviors. It's highly prevalent disease in the United States. It encompasses any alcohol use that increases the risk or likelihood of health consequences. That's defined as hazardous use. Alcohol use that has already led to health consequences for the individual is defined as harmful use. And then harmful use that meets DSM-5 criteria is equivalent to an alcohol use disorder. We talk about binge drinking, heavy alcohol use, high intensity drinking. These are detrimental, harmful levels of alcohol use to the individual. But in this country, the last time we have survey data, 2022, past month binge drinking, which involves, again, if you're a male drinking 5 or more drinks, a female drinking 4 more drinks on one occasion, 24% of Americans, close to 60 million adults, engaged in past month binge drinking. And what's more importantly is 30% of our young adults participated in binge drinking in the past month. When we talk about heavy alcohol use, we talk about the weekly definition, 14 or 15 drinks per week for a man, greater than 7 or 8 drinks per week for a female. And that applies to if you're older than 60 years of age. And then heavy binge drinking of heavy alcohol use is drinking in a binge pattern greater than 5 days per week. When we look in this country, close to 6% of adults have participated in past month heavy alcohol use, and nearly 8% of young adults have participated in past month heavy alcohol use. When we look at the 2019 Margin of the Future survey, in terms of high intensity drinking, that is drinking above the heavy episodic drinking levels, 12% of college students participate in high intensity drinking, which is associated with more negative consequences than the minimal threshold level of drinking. In terms of diagnosing an alcohol use disorder, the Diagnostic and Statistical Manual of Mental Disorder, the 5th edition, the criteria used in that tool is the gold standard. Alcohol use disorder is a chronic psychosocial behavior condition characterized by impaired control, social impairment, risk use, and pharmacological dependence. This tool, the DSM-5 diagnostic criteria, identifies the 5 C's and 3 R's of alcohol use disorder. The first criteria, the first 4, relate to impaired control. There's a loss of control over the alcohol use. You're drinking more over a longer period of time. There's an inability to cut down. Even though you've attempted in the past, you can't achieve abstinence or reduction in your alcohol use. There's a compulsive use of alcohol that the majority of your time is spent obtaining alcohol, consuming alcohol, and recovering from the effects of alcohol. And the 4th C is cravings. There's an overwhelming neuroadaptive process that undergoes in those who have an alcohol use disorder, where the drive to have that next drink because of cravings and the desire to avoid withdrawal really dictates how you interact with alcohol. When we talk about role failures and relationship issues, that's criteria 5 to 7. Those are result because of alcohol use and impairing your ability to do the normal things that are productive in terms of major roles and obligations, and then interpersonal relationships. Criteria 8 to 9 is the risk of bodily harm and consequences of your drinking. And then criteria 10 and 11 result in tolerance, where you have to drink more over time to get the same effect from the alcohol. And then the criteria 11 is the classic withdrawal syndrome, because you have developed psychological and physical dependence on alcohol, that when you don't expose your brain to alcohol in a timely fashion, you develop withdrawal symptoms. Once you actually use the tool of the DSM-5 criteria to establish an alcohol use disorder, you can gauge the severity. If you have 2 or 3 of these criteria, you have a mild alcohol use disorder. 4 to 5 of these criteria is consistent with a moderate. And then if you have greater than 6 of these criteria, you have a severe disorder. Moderate and severe alcohol use disorders, those individuals who meet DSM-5 criteria for those severities should have an informed discussion about FDA-approved medications to treat their disorder. Unfortunately, in this country, alcohol use disorders continue to be the most prevalent substance use disorder in the United States. Since 2020, the National Survey on Drug Use and Health has measured DSM-5 alcohol use disorder, and as a result have captured more cases of alcohol use disorder. That's why you see the jump from about 14 million pre-pandemic to about 27 million adults in 2020 who had an alcohol use disorder. The last survey, it's always a year in behind, but the last survey data were completed in 2022, and 28.8 million adults had an alcohol use disorder, outpacing the aggregation of all other substance use disorders. Alcohol use disorder affects white men predominantly, with a continued demonstration of a narrowing gender gap between male and females. And in the case of adolescents, over the last 2 years, in terms of monitoring alcohol use disorder in adolescents, there's been a reversal of that gender gap, where in 2020, there were more young adolescent females who had an alcohol use disorder than compared to men. Unfortunately, in 2022, 11% of Americans struggled with an alcohol use disorder. 62% of individuals with a substance use disorder in this country had an alcohol use disorder. That's 1 in 9 adults with an alcohol use disorder. 12.1 million adults had a moderate or severe alcohol use disorder, which was 41% of all DSM-5 alcohol use disorders in this country. And again, those individuals, according to treatment guidelines, should be considered for FDA-approved medications. In 2022, about 5% of individuals with an alcohol use disorder sought or thought they should get treatment. And in 2022, 7.6% or close to 2.2 million individuals actually received treatment for the alcohol use disorder, and treatment could be inpatient treatment, counseling, outpatient treatment or counseling, medications, telehealth, or treatment received in the criminal justice involved system. Out of that, unfortunately, only 2.2% out of the close to 29 million individuals with alcohol use disorder in this country received medications for alcohol use disorder in 2022. When we look at alcohol use disorders across a lifetime, when we talk about DSM-5 lifetime alcohol use disorder, that impacts close to 30% of individuals in this country. Out of those 30% of individuals in this country who have a DSM-5 alcohol use disorder diagnosed across their lifetime, close to 10 million will have a severe alcohol use disorder. Close to 33 million adults have a past year DSM-5 alcohol use disorder. And out of that subset, about 1.1 million will have a severe alcohol use disorder. This is just highlighting the large amount of individuals who have a severe alcohol use disorder, the severest in terms of the disease, and highlights the need for really focused treatment, focused counseling, focused medication for these population of individuals with the severest of the disease. Unfortunately, disparities exist in alcohol use disorders. More than 1 in 5 Native Americans will have a severe alcohol use disorder during their lifetime. And then it has no chronological preference. 1 in 6 adults from age 18 to 29, or adults age 30 to 44 will have a severe alcohol use disorder during their lifetime. Unfortunately, the mean age of a severe alcohol use disorder in terms of onset is 23 years, which is a 3-year lag before the age of any first initial treatment. Next, we'll review alcohol-related morbidity and mortality. I call the last 15 years before the pandemic a past decade of reckoning. From 2003 to 2017, 5% of all deaths were associated with excessive alcohol use. There was a significant increase in gender, females predominant, racial, Blacks, and age greater than 65 related hazardous alcohol use past year and lifetime DSM-4 alcohol use disorders in this country. Alcohol-associated hepatitis, hospitalizations and mortality, alcohol-associated liver disease, related hospitalizations were greater in females. In women younger than 34, there was a 146% increase over this time frame compared to a 41% increase in alcohol-associated hepatitis and alcohol-associated liver disease healthcare utilization. Alcohol use disorder treatment, including medication for alcohol use disorder, is vastly underutilized. When we look at mortality modeling, it suggests if alcohol use disorder treatment was extended to 40%, only 40% of individuals with an alcohol use disorder, deaths could be decreased by 13%. Alcohol-associated liver disease related mortality has significantly increased over the past 2 decades. Over a 24-year period from 1999 to 2022, there was about 437,000 alcohol-associated liver disease-related deaths, with women significantly driving the 105% increase in age-adjusted mortality compared to men. Both young and old cohorts demonstrated greater mortality rates in recent years, highlighting the impact of high rates of alcohol use in these groups. There's been ample work done on the alcohol-related mortality, racial and ethnic disparities. This is data from 1999 to 2020, and looking specifically during that time, there was 606,000 deaths related to alcohol. From 2018 to 2020, all racial ethnic groups showed an annual increase, except for American Indians, Alaska Natives. Blacks had a 17% increase, whites a 14% increase, Latin 13% increase in mortality over this time frame. And of course, the disparities are high among our younger adults, and then increasingly disparities exist in terms of our American Indian, Alaska Native individuals who die at a higher rate compared to whites. Their females die at a higher rate, and then their younger cohorts have higher rates of disease prevalence in terms of age-adjusted mortalities. Excessive alcohol, if we remember that definition I talked about when we first started the talk, it's characterized by binge drinking or heavy alcohol use or any alcohol use in someone younger than 21 or a pregnant person. Excessive alcohol use is one of the top 3 causes of preventable deaths in this country. In 2020 to 21, it contributed to 178,000 deaths, which when you look at the time frame from 2016 to 2017 to 2020 to 21 was a nearly 30% increase. And again, we see female driving that increase in terms of mortality. When we look at the diseases that are 100% alcohol attributable, like alcohol cirrhosis or alcohol-associated hepatitis, there was nearly a 50% increase in terms of mortality over this time period from 2016-17 to 2020-21. And then acute alcohol overdose deaths, which we commonly call alcohol poisoning, increased 46% over this time frame. And so before or straddling the pandemic, we were dealing with escalating rates of alcohol attributed harms, including mortality and morbidity. And what we really realized is that during the pandemic, those things only became exacerbated. This is a nice study looking at alcohol-related deaths over a period of time before the pandemic. The 2 decades prior to the pandemic, the annual age-adjusted deaths increased by 26% between 2019. I'm just looking at the chat here. I know I didn't take the time to stop, so 1 second. I can't get in there without getting out of my screen. And then 10% between 2020 and 2021. Alcohol-associated liver deaths increased by 12% over that time frame, and then drug overdoses, concurrent other substances in combination with alcohol use increased 13%. And then a thing that I found very interesting is that alcohol-related traffic fatalities had been on the general decline for decades, but after the pandemic, those figures increased by 14%, all showing and consistent with multiple research analysis that showed because of the social isolation, the increase in psychosocial stress, that alcohol use increased significantly during the early part of the pandemic and likely continues at this point in time as well. Alcohol-related deaths increased 26% during the pandemic. And kind of the same figures when you look at January, February, March 2020, and then the first US state issue stay-at-home in March 20, there was a dip in terms of alcohol-related deaths, but that increased exponentially and quickly as the pandemic progressed, as again, individuals consumed more alcohol. Alcohol-associated mortality increased for all groups, again, more so for our younger individuals. And in this particular scenario, there was no gender difference between men and female. Alcohol-associated liver deaths increased 22%, And more importantly, alcohol-related mental and behavioral deaths increased 35%. Alcohol-associated related deaths outpaced all-cause mortality by 17%. All other causes of deaths were surpassed by alcohol-related deaths during the pandemic. And then fentanyl and alcohol-associated overdose, the concurrent use of substances reflecting multi-substance use disorders increased nearly 60%. I want to move on to the third objective and talk about highlighting alcohol-associated liver disease, which we call ALD, and then define this concept of the dual pathology of alcohol use disorder cirrhosis. When we talk about alcohol-associated liver disease, it's a clinical pathological spectrum. What we can't see is fatty liver steatosis, but when you drink for a long time, your liver starts to develop fatty droplets, and it looks like a fatty liver when we look at it radiographically. That progresses to a state called steatohepatitis that we don't know externally exists, but is the beginning of a chronic inflammatory state reflecting the injury from the toxic effects of alcohol in the liver. The first clinical manifestations of that chronic injury is what we call alcohol-associated hepatitis. If you continue to drink in terms of surviving that initial episode of alcohol-associated hepatitis, you will develop fibrosis, and that is scarring of the liver, which result in fibrosis and dysregulation and disruption of the hundreds of critical important functions of the liver. And if that continue in terms of drinking, you develop alcohol-associated cirrhosis, where there's scarring of the liver is dysfunctional, and you are at risk for hepatic decompensation or liver failure or hepatic cellular carcinoma. In terms of alcohol-related emergency department visits and alcohol hepatitis admissions, both increased during the pandemic. When we look at the drug use warning network, alcohol was involved in nearly 40% of all drug-related ED visits, nearly 3 times opioid-related visits. And we know from multiple sources that alcohol-associated hepatitis admissions increased, not only in the very beginning of the pandemic, but throughout the first year of the pandemic, and continues to be a challenging public health issue. When we talk about alcohol use disorder and cirrhosis, we're redefining what alcohol use disorder looks like in the context of advanced alcohol-associated liver disease. Alcohol use disorder complicated by AALD. Right? AALD is the direct liver complications, and then alcohol use disorder is the root cause of the liver disease. There's emerging literature, and the way I practice is you just can't treat one part of this spectrum. You just can't focus on the alcohol use disorder. You just can't focus on the direct liver complications. You have to manage the medical and psychological components of the direct liver complications, but you also have to really address the root cause of why that individual has alcohol-associated cirrhosis. This requires an optimal care model that involves addressing the biopsychosocial cultural factors of alcohol use disorder and the medical and psychological aspects of advanced alcohol-associated liver disease. And we as providers make sure that we take the opportunity at every healthcare encounter that we're screening for unhealthy alcohol use, we're making the correct diagnosis of alcohol use disorder, and if it's moderate to severe severity, we're having mutually shared decision-making conversations with individuals with moderate to severe disease about the different avenues or pathways to, one, control their drinking, or two, abstain from drinking if that's what they desire. And again, the opportunity to talk about the life-saving, life-preserving aspects of medications for alcohol use disorder. Alcohol use disorder is a major health issue. From 1998 to 2018, hospitalizations increased from about 46,000 in 1998 to 70,000 in 2018. The mean age of the individuals who are surviving alcohol use to cirrhosis is increasing, which is reflecting patients are sicker but older, and they're surviving longer because of the yeoman medical technology that we have employed to treat this chronic severe disease. Patients are sicker, but again, surviving longer. Hospital costs have increased 2.1-fold. Hospital costs for alcohol use disorder cirrhosis admissions were 2.8 billion in 2016. So you can imagine that figure is much higher. And unfortunate, like other things in terms of unhealthy alcohol use, alcohol-related harms and mortality, there's significant disparities that exist. Even though mortality has significantly decreased from about 13% to 5%, Black patients continue to die at a higher rate. And those who are sicker are more likely to die. And interestingly, there's no gender differences between a female who has alcohol use disorder cirrhosis and a male who has the same disease. Over the past decade, in terms of healthcare utilization, alcohol-associated liver disease-related transplants have increased 126% in adults. In 2021, alcohol-associated liver disease accounted for 40% of all transplants. That's the #1 etiology. 10 years ago, it was the 4th etiology. In 2023, liver transplants continue to increase at record levels. As of September of last year, there was 811 more liver transplants compared to the previous year, 2022. And this procedure of early liver transplantation for severe alcohol-associated hepatitis is the likely driver. Over the past decade, non-alcoholic steatohepatitis transplants have increased 165%. It's now the #2 etiology, where it was 20% of all transplants in 2021. And fortunately, because we now have medications that essentially cure chronic hepatitis C or hepatitis C cirrhosis, those transplants have declined 70% over the past decade. Alcohol-associated hepatitis liver transplants have exceeded forecasts during the pandemic. When we look at the waiting list registrations and actual liver transplants, they've increased by more than 60% respectively. And this is positively correlated with the record monthly retail alcohol sales that we saw in the beginning of the pandemic. There's a well-studied temporal association and positive correlation with increasing alcohol use and the development of a severe alcohol-associated hepatitis and the indication, the acute indication for alcohol-associated liver transplants. There's been no change in transplants for alcohol-associated cirrhosis or non-alcohol-associated liver disease over the same period. So alcohol, the increase in alcohol use as a result of the pandemic, though this increase was continuing to exist before the pandemic, but exacerbated by the pandemic, the large increase in monthly retail alcohol sales and consumptions by many populations in this country have been the drivers for the record amount of not only alcohol-associated waiting list registrations, but alcohol-associated liver transplantations during this time. Alcohol-associated liver transplants increased close to 270% during the pandemic. The waiting list increased 325%. There were 13 more alcohol-associated liver transplants per month performed during the pandemic, and the median age is 41. So the onset in terms of alcohol-associated liver failure requiring the thought of a transplant is happening before someone leaves their 3rd decade of life and barely before they enter their 4th decade. And there's no difference between pre-pandemic and pandemic cohorts. Alcohol-associated liver disease is a significant driver of transplantations in this country. So I want to finish this talk and talk about medications for alcohol use disorder. Pharmacotherapy for alcohol use disorder. There's FDA-approved medications for moderate to severe alcohol use disorder. It includes delsulfiram, which was introduced in the market in 1949, acamprosate in 2004, oral naltrexone in 1994, and then an injectable form in 2006. Most clinical trials of medication efficacy studied individuals with a DSM-5 for a DSM-4 alcohol dependence diagnosis, which is imprecisely compared to DSM-5 moderate to severe alcohol use disorder. They're not really stringent guidelines. The 2018 American Psychiatric Association guidelines recommends first-line treatment with acamprosate or naltrexone. And then they suggest off-label medications, including gabapentin and topiramate, if initial treatment is effective with a first-line agent or is not tolerated by the patient. When the patient prefers to do something else, there's no clinical trials that have studied alcohol use disorder pharmacotherapy in hospitalized patients, and there's limited clinical trials that have studied patients with alcohol use disorder cirrhosis. When we talk about the categories of medications, naltrexone is a mu opioid receptor antagonist. It's an opioid receptor blocker. It prevents the alcohol from activating opioid receptors in the brain, which results in the euphoric or the feeling good feeling that you have when you drink. And so it eliminates that pathway. It also helps with cravings. When we talk about disulfiram, it's an aversive agent and it's an aldehyde dehydrogenase inhibitor. When you drink alcohol, you develop an ethanol disulfiram interaction. Secondary to acetaldehyde accumulation results in nausea, vomiting, flushing, just an unwell feeling that is supposed to be the deterrent to drinking. It has no impact on CNS pathways that underlie alcohol use disorder. Acamprosate is a glutamate receptor antagonist. It attenuates alcohol-associated elevations through its actions on the NMDA receptor, and topiramate works the same way. We have GABA agonists, including gabapentin and topiramate. And then gabapentin and topiramate also have are anticonvulsants that have their mode of action to GABA receptors, which are responsible for some of the reactions to drinking alcohol. When we talk about medications and we look at population studies, not focused on clinical patient-related outcomes, but actual healthcare utilization in terms of emergency department utilization, hospitalizations. One of the better longitudinal large cohort studies is out of Sweden, which actually has a state-funded healthcare system. So they're able to monitor all aspects of their patient populations who are engaged in medical care. And this particular study looked at close to 126,000 residents who received first-time treatment for alcohol use disorder. And what they looked at is alcohol use disorder related hospitalization, all-cause hospitalization, all-cause mortality. And what you see is when we look at naltrexone, there's 11% decrease in alcohol-related hospitalization for those individuals with alcohol use disorder who take naltrexone. You can actually see that acamprosate has a negative effect in terms of alcohol-related hospitalizations. When we look at these medications and combinations, and they also impact all-cause hospitalizations, and none of them significantly impact all-cause mortality. But benzodiazepines, which are frequently used to treat alcohol withdrawal, are associated with increased all-cause mortality. When we look at the combination of medications, the longer our patients are on medications and combinations of medications, including naltrexone and acamprosate, in this particular population study, hospitalizations were reduced for individuals with severe alcohol use disorder by 29%. Longer durations on naltrexone treatment was associated with a 52% lower risk of alcohol use disorder hospitalization. And that's durations greater than 6 months compared to taking the medication for less than 30 days. And so like other medications for chronic medical diseases, patients will go through periods of adherence to their medication regimen and lack of adherence. And so the message critically for patients, especially those with severe alcohol use disorder or alcohol use disorder cirrhosis, is that taking your medication will save your life. And so as long as you take that medication, you will benefit from the protective aspects of the medication. FDA-approved medication impacts morbidity and mortality, and specifically with alcohol use disorder cirrhosis. Those who take these medications have a 24% less likelihood to develop alcohol-associated liver disease. Those who develop alcohol-associated liver disease and take medications for alcohol use disorder have a 55% less likelihood of experiencing that first hepatic decompensation in terms of their alcohol-associated liver disease. And those individuals who are prescribed medication for alcohol use disorder in the first year after alcohol use disorder cirrhosis diagnosis demonstrated a 20% decrease in mortality. And those, again, has shown in the population study in Sweden, those individuals who take their medication for alcohol use disorder for a longer duration actually have beneficial and increased decrease in mortality. And what's interesting, if you have a conversation with an individual with an alcohol use disorder in clinic and you try to address or listen to their concerns about their alcohol use and determine whether they have an alcohol use disorder and think about treatment options that are patient-centric, that conversation alone within 1 year of an alcohol use disorder cirrhosis diagnosis resulted in an 11% decreased risk of developing hepatic decompensation or acute liver failure. Psychotherapy is also associated with improved alcohol use disorder cirrhosis outcomes. This is a nice study of the Mass General Brigham Biobank, about 9,600 patients who have alcohol use disorder, and it looked at the long-term impact of psychotherapy. Those who participate in psychotherapy, whether individual or group, had a 41% decrease in the incidence of alcohol-associated liver disease after an AUD diagnosis. There was a 32% decrease in incident hepatic decompensation after AUD cirrhosis diagnosis. And then the type of psychotherapy is important in terms of preventing that incident episode of development of alcohol-associated liver disease. 30% decrease with individual psychotherapy, 24% decrease with group therapy. Unfortunately, there was no significant impact in terms of hepatic decompensation. But what this really shows is that we have in our armamentarium a number of interventions to help someone who has a moderate to severe alcohol use disorder or complex alcohol use disorder in the context of alcohol use disorder cirrhosis, whether it's medications, FDA-approved medications, or individual or group psychotherapy. Large population studies, including those at Mass General Hospital, have shown that medications and psychotherapy, one, impact the morbidity and mortality of individuals with moderate to severe alcohol use disorder, and then in that really severely ill population of individuals who have developed, unfortunately, alcohol use disorder cirrhosis. In terms of best practices, whenever we talk about what medications to use, and this is something that really, is a challenge for our frontline providers. But if we're talking about moderate to severe alcohol use disorder, I look at first-line agents like oral naltrexone, extended release naltrexone, especially when I'm doing the DSM-5, using the DSM-5 tool to determine the severity of their disease. If there's a presence of cravings or what I call preoccupations, when I see a commercial for alcohol on television, it just sets off a chain of events on the CNS level where I have to get a drink of alcohol. I can't think about anything else other than getting that drink of alcohol. Extended release naltrexone or oral naltrexone are very effective for those kinds of thoughts. Topiramate has been shown to be an emerging, probably equivalent to oral naltrexone and extended release naltrexone in terms of treating individuals with moderate to severe alcohol use disorder. Some of the second line agents, really, if you're thinking about those, you should be talking to an addiction psychiatrist or addiction medicine specialist. And then when we talk about alcohol use disorder cirrhosis, for me, the first line agent is always extended release naltrexone. These are our most at risk populations of individuals at risk for progression to decompensated disease, acute liver failure, the need for transplantation evaluation. And so I'm always talking about with these individuals about injectable naltrexone, so they don't have to worry about taking a pill every day, and they can benefit from the the really favorable pharmacokinetic profile of injectable naltrexone, where once you get an injection, the medication is therapeutic in your body over the course of a month. No matter what conversation we have with a patient about medication, it has to be patient-centric focused. It has to be in line with the patient's goals and wishes, but also need to be informed about the choice and of these medications and then the efficacy. And then when I mean efficacy, I mean population studies that I just reviewed that show that these medications are life-saving. So we come back to the ADAP model where we talk about awareness, making the correct diagnosis using a standardized tool, and using that tool not only to make an initial diagnosis, but also to follow a patient over the continuum of care to see how they're dealing with their disease. Just like other chronic diseases, hypertension, diabetes, you're going to have ebbs and flows. You're going to have periods where patients are doing great, and you're going to have periods where patients are struggling. Alcohol use disorder is the same. And so we have to really be able to have a tool to really assess when our patients are doing well and when they're not doing well. And when they're not doing well, have the tools to actually address or recommend changes in discussion with the patient about what they want to do in terms of getting back to the period when they were doing well. We talked about assessments, and which is really social cultural assessment. I didn't really talk about trauma, but trauma is such a big factor in individuals who develop not only alcohol use disorder, but other substance use disorders. The aggregations of traumatic experience, whether in childhood or adolescence, over the course of a lifetime, contribute to early onset of alcohol use, early onset in terms of development of alcohol use disorder, and then intergenerational impacts that are more profound than possible in terms of the impact downstream in terms of how it affects offspring. And more importantly, we talk about prevention. Once we diagnose someone with an alcohol use disorder, we need to be having conversations with that individual about the complications and then thinking about prevention, including preventing the development of alcohol use cirrhosis. And as I've shown here, medications prevent not only the development of alcohol use disorder cirrhosis, but also the progression of that disease entity. And then more importantly, the thing that is core with every patient and should be discussed with every patient with a moderate to severe alcohol use disorder is providing trauma-informed, non-stigmatizing alcohol use disorder care. There's already enough personal and internal stigma and guilt and shame about alcohol use by many of our patients. We don't need to reinforce that behavior. We don't need to reinforce that shame and guilt. We should be open-minded, empathetic, compassionate, and really engage this vulnerable patient population on what they can do in terms of trying to achieve recovery. And if their goal is not abstinence, that's okay. How can we talk about harm reduction interventions that allow them to drink less and subject their liver and other vital organs, including their brain, their heart, their pancreas, to less toxic effects of alcohol? So in summary, alcohol use disorder is the most prevalent substance use disorder in the United States. Close to 29 million adults in 2022 had an alcohol use disorder. We've seen not only the narrowing of the gender gap, but the reversal in early adolescence. I don't know if that's going to be a harbinger of things to come, but the data to date suggests that more women are using alcohol in an unhealthy way, suffering from the consequences of unhealthy alcohol use and contributing to significant increases in healthcare utilization and costs. Unfortunately, only 2.2% of individuals received medications for the alcohol use disorder, but that's in conjunction with only about 3% who felt they needed treatment. Increased alcohol use is driving healthcare utilization. This was demonstrated pre-pandemic and it's continued during the pandemic. The long-term impacts are unclear. Alcohol use disorder cirrhosis represents a dual pathology with significant morbidity and mortality. Alcohol-associated liver disease morbidity and mortality was increases pre-pandemic. It significantly increased during the pandemic. It's an emerging public health crisis. alcohol-associated liver-related diseases are projected to increase from 8.2 to nearly 15 per 100,000 person years in 2040. So we're going to see a worsening of healthcare utilization and cost, and not only that, tremendous intergenerational despair for individuals who have alcohol-associated related liver deaths. Unfortunately, there's a dearth of clinical trials studying pharmacotherapy efficacy and safety in alcohol use disorder cirrhosis. I can tell you from my clinical practice, I see no efficacy or safety concerns with using these medications in individuals with alcohol use disorder cirrhosis. And it's one of the forefront tools I use in terms of trying to control individuals who have this disease entity. Population studies, including ones done at Mass General, demonstrate pharmacotherapy in alcohol use disorder cirrhosis is underutilized, but associated with significant improved patient outcomes in terms of advanced alcohol-associated liver disease incidence, the progression of decompensated disease, emergency department and hospital utilization, and then, of course, the tremendous impact on mortality that these medications bring to a patient's treatment plan. Pharmacotherapy in patients with alcohol use cirrhosis is life-preserving, more effective than behavioral treatment. But again, we saw the positive benefits of psychotherapy. And the ADAP model is an approach to optimize personal care of alcohol use disorder, thinking about the individual in front of you, trying to create an atmosphere that's humanizing, non-stigmatizing, supportive, and actually listening to the needs of our patients with alcohol use disorder is critical. And then there needs to be an urgency and recognition, diagnosis, and treatment of alcohol use disorder. It's projected to be not only an ongoing public health crisis in this country, but it's going to strain our healthcare utilization in terms of how we deal with these very, very sick cohort of patients moving forward. So with that, I'll end and we'll take some questions.
Thank you. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding what is MGH doing to raise awareness and address alcohol use disorders?
I would say not as much, not as much as they should. I think there's in this country, there's a duality or a dichotomy of how we view substance use disorder. There's a focus on opioids because we see the immediate loss of life, the tremendous amount of intergenerational despair causes, and we understand that it exists in an illicit manner. For alcohol, it's legal. It's part of our culture. You see it everywhere you go. When we talk about alcohol outlets in terms of density in Black and brown communities, there's an alcohol outlet on every corner. And we are primed over the decades to think that alcohol use is a normal part of life. No one talks about that alcohol is a toxin to many organs, including the liver. And that I will say is because of the billions of dollars that go into creating this image that alcohol is fun and alcohol needs to be engaged with to feel like you fit in. I tell every single patient that alcohol is a toxin to every organ in the body. And so we have to deal with that dichotomy that we as a society view alcohol and opioids. I look at alcohol the same as opioids. Opioids are the same as alcohol. They kill hundreds of individuals every single day. How do we get that message to the leaders of our system? I think is an ongoing conversation and discussion.
Thank you. And are you able to briefly describe what services, programs, and supports are available at Mass General?
So from my perspective, where I see patients who are hospitalized, fortunately with complex alcohol use disorders, I think that's the first initial contact. I find I'm having a lot of first conversations with individuals with alcohol use disorder who fortunately are suffering the consequences in terms of alcohol use disorder, cirrhosis, alcohol-associated hepatitis, or alcohol withdrawal. And so the first part is really talking about in an open manner so that individuals understand the effects of prolonged excessive alcohol use, how it's resulted in development of alcohol use disorder, and then how do we think about creating a life that doesn't include alcohol? And those are some of the challenges. In terms of the services we provide, we have behavioral counseling, we have individuals with lived experience who are now practicing or have achieved recovery and can talk to individuals how they got there, what it was like. And then more importantly, we spend a lot of time in the hospital creating an atmosphere or culture of acceptance, right? We're not going to blame anybody. We're not going to shame anybody. We're going to try to be educational, increase awareness, and hopefully teach individuals who are suffering from the complex repercussions or consequences of their alcohol use about how they want to move forward in terms of that. We have outpatient clinics, our Mass General Bridge Clinic, Brigham, Haverhill, Salem Hospital, where we have specialists, including clinicians, psychotherapists, individuals with lived experience, so that we can connect individuals with community-based resources, which is critical to control their disease in the long term.
Thank you. And are there any online resources that you would recommend for someone to learn more about alcohol use disorders and getting help?
Oh, sure. The federal websites are NIAAA.org, and you could just plug that in and you'll see a host of conversations about unhealthy alcohol use, resources, current treatment. The CDC has a wonderful website as well, where they talk about excessive alcohol use and the cost, the utilization, the morbidity, mortality, and the ability to identify providers and also think about life-saving medications for that disease.
Thank you. And it looks like we're about at time, but before we end today's session, do you have any final thoughts you'd like to share with the audience?
So my final thought is, if you're, again, 1 in 9 adults in this country have an alcohol use disorder. So we all know someone with alcohol use disorder. And the first part for us, if we know someone with alcohol use disorder, is changing how we look at the disease, right? It's a chronic disease that's treatable and preventable. And so how we create a warm, loving, compassionate, empathetic relationship with someone with alcohol use disorder goes miles. It allows them to really think about how they want to talk about and address their disease, but also allows them the psychological safety to be vulnerable to talk about it. There's no fear or shame. And so that's what we try to create when we see patients on the addiction counsel service. And it's the advice I give to any loved one of someone with alcohol use disorder.
Thank you so much, Dr. Lambert. This was extremely helpful.
All right, thank you.
And for everyone who joined today, thank you so much. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.